advice, do not stick your fingers in there, because if they seize, they're gonna chew your finger off, okay? So you wanna make sure that they are paralyzed, okay, before you stick your fingers in their mouth, or unconscious, or whatever, but don't be sticking you. So you can do what they call the scissor technique, which really is just doing this with the upper and lower jaw, okay? But I find even if you just tilt his head back, it's fine, his mouth opens. Okay, so you don't have to be sticking your fingers in his mouth. Torso mannequin, you might have to actually open his mouth up a little bit. Okay. So we're going from right to left. Okay, and really all you're doing is just put it in about halfway and have a look. Do you need to suction? You'll know right away by opening the mouth and looking whether you need to suction the oropharynx or not. Okay, so I'm looking in there, nope, we're good, don't need to suction yet. Okay, at this point you can pull up. You want to go that way with your laryngoscope towards the wall. Okay, you don't want to be doing this. Okay, there'll be none of that. It's all this action. Okay, so you're going this way with it.
And we'll be watching for that. That'll be the conversation. If I said we say you're rocking, that's what we're referring to. Or rocking.
And that's something that you can watch other people if they're doing it. You can say, just a second, you're rocking back, you would actually break the teeth. Okay? If you're hearing this, okay, that means the teeth are broken. Okay, that's rocking back. So I shouldn't hear that at all. So you want to look visually. I'm not using a hell of a lot of strength to open it. So if people are doing this, they're doing something wrong. Okay, it doesn't need a lot. Oops, lost them visually. Oh, here we go. Now we're back. So we've got a bit of space between the upper teeth and the blade. Okay. When I was in lab, I used to go around, stick my little finger in there and say, okay, go ahead and intubate. They go, put your fingers in there. I know, it's all good. Just forces you to make sure you're pulling upward. Ooh, tough.
So we should imagine your fingers in there.
That's right. God, Heather's fingers in there. Oh my God.
Make sure it's Heather's fingers. She trusts you more than I do.
Yeah. So make sure you visualize it. You can actually see it. I can kind of see it because I'm not scooped down far enough. Sorry, guys. Just gonna bend them up a little bit more here. There.
Oh, she's everything that she said it about ergonomics.
Okay.
It's pretty impressive, actually.
If you see it go through the cords, it's in the trachea. If you don't see it go there, it's probably not. Okay. So I see the cuff is at the cords. So I'm going to push it down a little bit more. Okay. At this point, if you wanted to, you can actually pull the stylet back a little bit. It gives it a little bit more flexibility. It's just sticking. Sticky. Yeah, no, it's okay. I think we're good. Thanks. Okay. Normally you wouldn't leave it like this. You got about 30 seconds-ish.
30 seconds.
30 seconds is lots.
Feels like an eternity, actually. 30 seconds when you're doing this feels like forever.
So you don't want to let go of the endotracheal tube. You're going to be holding it. Okay. You're going to pull the laryngoscope blade out gently. There should be none of this. Okay. Nice and gentle. Okay. I can hold this. Pull out the stylet gently. Again, if you pull it out really hard, you're going to pull out the endotracheal tube as well. Inflate the cuff. And then I'll get my Vanna White here to bag for me. Oh, good, it's in. Okay. And then we check to make sure that what? What are we looking for?
Chest movement.
Bilateral chest movement. What else should be happening? CO2. Okay, what color should it be turning? Yellow. Yellow, yay! Okay, That's how you remember that. Yellow. Okay, should be turning yellow. Sat should be good for the patient as well. I get my stethoscope and I'd listen to the chest. I'm gonna listen over the stomach, make sure I'm not getting air in the stomach. You're gonna get some patients that are really big, okay? And if you're in the stomach, it looks like their chest is rising, but it's in the stomach. Okay, so listen over the stomach, listen over the trachea. And why am I listening over the trachea? Is that leaks? Absolutely. Yeah, see if do I have enough volume in the cuff? Okay. Okay, now what? Mama Nadine?
All right, in post-intubation management, well, actually, first of all, we have to secure the ECT.
Yes.
The rest we do.
It's too short. It's okay.
That's the one I have.
I know. We all do this a little bit differently as well. Well, that's okay. We're allowed. So, Aaron would be holding the endotracheal tube while I'm playing with the ties. Okay. There is a video on twill tying under somewhere in Moodle. Somewhere there. Okay. And it's actually Emily, Kale's girlfriend, that's showing you how to tie. I'm going to do it kind of. So I'm not going to get. There we go. You can do a short version of it. So it's basically like a half hitch around the endotracheal tube. I'm tying it above, I'm tying it below, and then I'm going to go around the head. And I'm going to tie it on one side, and it's usually on the opposite side of where I've got the endotracheal tube. So if the endotracheal tube is sitting on the right-hand side of the mouth, I'm going to tie it on the left-hand side of the face. Okay. And I'm going to tie it at the side of the face so that I can see it. Okay. If you tie it behind their neck, you won't be able to see it back there. You should be knotted. We're just going to be doing bow ties, okay, so you can take it off again and redo it, okay? But you can't see what's happening back there, so it's always good to have it on one side or the other. And that way, too, when you're changing position of the endotracheal tube, you can either cut it off or untie it and move it to the other side, and it's accessible to you, okay? So you're going to do a nice little bow tie so I can get it on. All right. Thanks, Aaron. Okay, so Aaron can now let go because I've got it stabilized. How do I check to make sure the stabilization is correct or not? Well, we're going to stick some fingers underneath. I should only be able to get 2 fingers underneath. Okay, if you can get your whole hand under, it's too loose. Oh. I got the back lines. Okay, so it's just way too loose if you can stick more than your hand in there. And opposite end too, if you can't even get a finger underneath, it's probably way too tight and it's going to cut their mouth. Okay. Twills are still used at St. Paul's and Surrey, I think, as well. There's a couple places that still use twill ties. It's for short term only. And then they will switch to a more expensive type of fastening device. And we'll talk about what those devices are in class as well. There's a whole bunch of them out there.
One of the things I would suggest is just watch, because if you put it too high, it'll slide right down, and then you're going to be able to get your whole fist in that spot. So just watch for how high up the back it is, because as soon as they move, it slides down. So you just have to be aware that that's something that we see a lot.
Yeah, especially during lab practical. You know, you got it tied, and you think it's great, and then all we do is move the head and go, oh, look. Oh.
And then we go.
Whee! Yeah, it comes back out again. Okay, so we stabilized it, and then we would go into post-intubation care, which is basically putting the patient on a ventilator, checking their vital signs, SATs, get a gas about 20 minutes later, most likely. Did I miss anything, Nadine?